Let's talk about origins and destinations, because those puppies in yellow are not covered. If you go to a diagnostic or therapeutic facility, or you go to a doctor's office, it is not covered. And guess what? Your patient could be bed confined, could be bed bound, could be only transportable on a stretcher, and a trip to a doctor's office is not covered by Medicare. Period. End of sentence. It is in the regulations and it is in the ambulance benefits policy manual that a trip to a doctor's office is not covered, nor is a trip to a diagnostic facility. You will find, however, if the patient is within their first 100 days at a SNF, the facility is supposed to pay for those trips. And you do not have to bill Medicare. In fact, don't let the facility pull that crap on you. I'm sorry, there's a 4-letter word. Because if it is statutorily excluded from coverage by Medicare, and it is statutorily required that the SNF pay for it, the bill goes directly to the SNF. It is within, if the patient is within their first 100 days at a SNF, there are services that are covered by the SNF. Because what's happening is the skilled nursing facility is getting a per diem amount of money. And included in that per diem amount is things like occupational therapy, physical therapy, transportation. Often, very often, you'll take a patient who had hip replacement surgery and now they go to the SNF for the rehab, and they're there while they recover and heal. And of course they're going to have to go for a follow-up appointment to the surgeon to see how they're doing. And of course they're going to go by ambulance because they need special positioning because they're still in pain. They just had their hip replaced. That is the SNF's responsibility. Okay? Now, patient can go to E, which is your assisted living facilities. They can go to a hospital-based, that's G, a hospital-based dialysis facility. Site of transfer. If you're taking a patient from an emergency to where you're meeting a helicopter, that would be a S to I. If you took the patient from the hospital to where you're meeting a helicopter or where you're meeting fixed wing, that's H to I. Those are covered. What if you take the patient from the airport, I, to the hospital, and the flight crew is taking care of the patient? It's the level of service rendered to the patient, and it's I to H. When you have something that is non-covered, you might want to go to Medicare and ask for denial. Denials are appropriate if the patient asks for it or if you need it for a secondary payer. So GY is a request for denial. There's a bunch of Gs, and we use these Gs. Here's ways I remember. GY is GY should they pay. GM is got many. GA is got ABN in hand. QL is when they quit living. Did you know you can bill for dead people? I will come back to that in just a couple minutes. GY is when you want a denial for the patient or for a secondary payer. Sometimes a service that isn't covered by Medicare, like a physician's office visit, you would do it as R to P. Maybe this patient lives at home. R to P GY. And what's going to happen is the patient is going to get a properly worded denial that will show them that this was a non-covered service. Or they will get something that invokes their appeal rights. So if a service is non-covered, you can't ask Medicare for the money, but the patient can. And every once in a blue moon, some patient will raise a ruckus, they'll call their congressman, and suddenly, lo and behold, Medicare will pay for a service that in a million years you never saw them pay, and you never will again. But the patient couldn't appeal unless they had that denial in their hand. So you're protecting the patient by doing that. So if it's statutorily excluded from coverage, you do not have to ask for a denial, but you might want to do it if it's appropriate for your patient or a secondary payer. However, we see it kind of like Goldilocks and the Three Bears. I'll finish and come to you. We see it being used too much, too little, and sometimes just right. And that's what you want. You want it used appropriately because Medicare tracks this information. They know that not every service is covered. They expect that you're going to ask for denial sometimes. It shows you to be a very smart ambulance service if you say to them sometime, hey, look, we want something denied. We need a denial. And we're not asking you to pay it. The mistake that happens is if you bill something like N to P, nursing home to physician office, and you think, well, it's non-covered, Medicare won't pay it. And here's what happens. Maybe they don't have an edit set up and they pay you. You know who's responsible for that? You. Even if they're the ones who screwed up and they paid you inappropriately, it's still an overpayment. And you're responsible to catch it. An ABN can be very handy for that situation when it's a non-covered service. And you can even bill Medicare when you have an ABN, and that's where you use a GA modifier, got ABN. So you're letting Medicare know you already told the patient that it was likely Medicare would not pay. Diagnostic facility or therapeutic facility that's exactly what they're doing. They're diagnosing something. It's a freestanding kind of a place. Residential, custodial facility, and E, that's assisted living. Okay. G is a hospital-based dialysis facility. H is a hospital. I is a site of transfer, whether it's where you're handing over a patient to fixed wing or rotary wing, or you're picking up a patient from fixed wing or rotary wing. That's I. So I can either be a destination or can be an origin. There's always two modifiers. One is the origin, one is the destination. J is a freestanding dialysis facility. R to J. N to J is a very typical thing to see. N is a skilled nursing facility. P is a physician's office. It's not a covered destination. R is residence, and S is scene, an accident, an MVA, you come from the scene. When you go for denials, you're asking for a GY, that's just a request for a denial. If you have an ABN in your hand, you can bill Medicare. You do not have to, but the denial you would use request is GA. So the patient is going to get an appropriately worded denial. The others, if you've got more than one patient in an ambulance, and ambulances are designed to take more than one patient, you put GM. And you note in the narrative section of your claim how many manys you have. So do you have 3 patients? You have 2 patients, and you'll see this, a mother and child are not going to be split up if there's a car accident, okay? And QL is quit living, and I'm going to come back to that, okay? Is that better? All right. The problem we see with denials is the one where facilities demand denials, and it is not, no, they have no right. The only person who can tell you to seek a denial is the patient. Only the patient. The Medicare benefits belong to the patient, so only the patient can ask for it. Denials continue to be sought when the problem is documentation. So you have transports that don't meet medical necessity, and you're sending them to get a denial. Why don't we try going back and educating the crews or talking to operations and seeing what's going on? Or maybe doing an internal audit and seeing what's going on. Okay? So you need to determine, is it a trip that didn't meet medical necessity? And if that's really the case, then getting a denial might be appropriate. Or is it a problem that maybe the crews need some extra support? Now let's talk about billing for dead people. This is one that a lot of emergency services miss. And this again has to do with dispatch. So, If you have a patient who is pronounced dead by someone who the state of Louisiana recognizes has the authority to pronounce them dead, and that happens before dispatch, they're pronounced dead. If you get a call, all you're doing is moving a body. But, and I'll talk about this again in a couple minutes because I'm going to go over ALS again. If you get dispatched for something, it is assumed you're going to a patient. So you could get dispatched for a man down, unconscious person, unresponsive, sick person. Those 4 scenarios, sick, unconscious, unresponsive, you believe you're going to a patient. So you get dispatched, you go to what you believe is a patient. Now, if you get to that patient's side and that patient is dead, Medicare recognizes there is a cost to respond, and they will pay you for going. They're only going to pay you at the BLS level, and you have to put the modifier QL on it. They will not pay you any mileage because you're not transporting the patient. The patient quit living. So you put the QL modifier on it. So if the time of death pronouncement is after dispatch, but before you loaded that patient on board the ambulance, then you get paid your base rate, no mileage, and you use the quit living modifier. The last scenario, you get dispatched to unresponsive. You go to that patient. You're working that call. That might be a cardiac arrest, respiratory arrest. This is a serious call. You load that patient on board the ambulance. You are working your tail off on that patient. You might have intubated. You've loaded them up with drugs. You've got IVs running, everything you could possibly do. And about halfway to the hospital, medical command calls it. You're done. Doesn't matter. That is billed at the level of service you were rendering to the patient, probably an ALS 2 level call. Is everybody comfortable with this? Does this make sense to everybody? Hopefully you've been doing it and it's not new information to you. Okay? So, we talked about EMS and we talked about BLS and ALS, and I told you how this is driven by emergency response, and I urge you again, have dispatch protocols available to the billing personnel so that you know where you can go, because an emergency is based on emergency response. An emergency response is one where an immediate response is one in which the ambulance begins as quickly as possible to take the steps necessary to respond to the call. And this is critical when we're talking about ALS assessments. Prior to 2002, you would get called out for something and you would have no control what you were being sent for. And if the patient said they had chest pain, paramedics would go. When the paramedics got there with a MICU, they would find out that the patient didn't need paramedics. Maybe the patient had a hot gallbladder. They needed to go to the hospital, or maybe the patient was having a panic attack and they needed to go, but they didn't need paramedics. So what happened prior to 2002 is we only had ALS and BLS, and you were bound by what you found when you arrived. Not what you were dispatched for, but what you found when you arrived. Now, it's based on how you were dispatched. So if you were dispatched for an ALS level issue, like chest pain, and you went to the patient's side and you performed an ALS assessment, and you documented it, then under the definition for ALS-1 emergency, it becomes an ALS-1 emergency. Even if the paramedic ends up driving and the EMT ends up in the back of the rig with the patient. What is critical to this is that all the pieces are documented. And by all the pieces being documented, number one, we need to know it was an emergency response. Number two, we need to know what you were dispatched for. So what was reported at the time of dispatch? Because if it was chest pain, only a paramedic is qualified to decide whether or not a paramedic is capable of taking care of this patient, or should be the one taking care. Not capable, it's not a capability, it's skill. Is skilled to be taking care of this patient. Only a paramedic can decide if a paramedic is needed. Now, we all know a good EMT certainly knows when a paramedic is needed, but the rules say, and that's what we're bound by, the rules say if you're going to get paid for this, then only a paramedic can decide. So, was there an emergency response? What is it you were dispatched for? Was it an ALS level dispatch? Was an ALS assessment performed? And last but not least, was this documented? If it was documented, it is an ALS 1 emergency call. This is one of the biggest areas where I see providers either shooting themselves in the foot and not getting paid appropriately, or doing the opposite, and that's billing everything ALS. Just because you have paramedics on board does not make it an ALS call. And providers have found this out the hard way by getting in trouble. Okay? All of the pieces have to be documented. And we used these two examples earlier of an emergency. Is it an emergency if your patient was found sitting in a chair and the documentation notes they had edema of the lower extremities? No, it is not. What many emergency providers believe is that because we were dispatched 911, it is an emergency. And this is where not only Medicare, but the payers are pushing back in our industry. And they're saying, we don't care if you were dispatched 911. This is also part of what's driving the movement to mobile integrated health and to community paramedicine, because not every call is a highly acute call. There's levels of acuity. And as the nation responds to this, and as we evolve in EMS, and I know you've got things that you're doing here in Louisiana, as there are in other states, you take someplace like MedStar. And if you've not checked out what they're doing, two big services in the country. One is MedStar, which is in Fort Worth. Matt Zavatsky runs MedStar, and the other is REMSA in Nevada. And what they've done is they looked at all of their calls and their volume, and they found that many of their patients, some of them their frequent flyers, were calling with things that weren't that terribly serious. And by turfing them to a nurse, this is what they're doing in Fort Worth, the nurse at any time can push the hot button to dispatch EMS, but they're finding that sometimes these are social services or other things that the patients need. If at any time in the question, in the decision tree, it's determined the patient needs paramedic or EMS, boom, they go. And this is not a question and answer that takes a lot of time. This has been tightly designed to be done quickly. But they're finding that not every patient who calls 911 necessarily needs a 911 response. But we in our industry have come to believe it was a 911 call, it's an emergency. Now, it's got to stand the smell test. And we have to be able to have support in our documentation. And this is the kind of call where you would look at that and you'd say, edema of the lower extremities. It sounds like something's going on. Maybe the medic can explain it a little further. That might be a trip addendum time. Or this might be trip addendum time. 90-year-old man found seated on a toilet. 911 call. Okay, whoopee-doo, it's a 911 call. Blood found in bowl. Well, if you're the one finding the blood in the bowl and it was only yesterday, I bet you remember what you saw. That might be trip addendum time. Okay? So, do any of you have a mobile integrated health, or are you doing any kind of CP services? If you're not, I'm going to tell you a way that you could bill for these services. This is not a covered service by Medicare, but many commercial insurers are looking at it. It is a code that is on the public use file on CMS. It is a code that has existed a very long time. It is called Treatment Without Transport, and the code is A0998. And you are doing some of this without even realizing you're doing it. You're going to a diabetic, and you might start the IV and the diabetic doesn't go, or you'll spend some time with the diabetic and the diabetic does not want to go to the ER. Or you respond to a motor vehicle accident, you assess everybody, and you maybe patch up or bandage up a bit, and then they decide they don't want to go. Now the next day they're sitting in the ER because the shock is worn off, but when you're with them, they don't want to go. There is a code for treatment without transport, and I've been recommending this to people who are putting in mobile integrated health or community paramedicine programs, and to people who are responding to calls and then you don't transport. This code has been on the list of codes as long as the codes for mileage, the codes for ALS1 and ALS2 and BLS. It's been there the whole time. And its definition is treatment without transport. This is a very good use of resources. Medicare will not cover it. Medicaid is just starting to cover it in some states, but commercial payers will use it, and certain ALS intercept services. So in Pennsylvania, sometimes we have separate BLS and ALS. In New York, they have separate BLS and ALS. So ALS will show up, and they may go back. They have used this code with success to commercial payers. All right? So it's just an idea. Put it in your arsenal in case you need it if you're doing those kind of services. And it is one of those things as we go forward where you're going to have to be careful. We're going to be educating the payers on this. Be a very long uphill battle before Medicare covers something like this, but the payers we may have to educate. So if you're going to do these kind of services, be careful how you price them. Do not shoot yourselves in the foot over this one. It is probably going to be in the range just below your average BLS fee for service, but start thinking about this because this is on the radar for everybody, all right? That this is a way that you could get paid for a very valuable service that you're rendering in your communities. And if you're not doing them now, you are probably going to be doing them at some time in the near future. ALS2. When you run your billing reports, check and see how many ALS2s you're doing. You would be doing probably between 2 to 8%. Closer to 2, it's closer to the low. But a lot of services miss this because they don't either have the documentation or they don't realize that when they attempt something or they monitor somebody else's work, it is still the same thing. So you already know about the 3 meds. If you're monitoring 3 meds, you're doing a hospital transport, and you're monitoring the 3 lines, as long as it's not dextrose, normal saline, or Ringer's lactate, then it's ALS2. Or if you're monitoring the intubation, if you attempted an intubation and you couldn't get it. I was working with a children's hospital in another part of the country, and this was fascinating because I really don't see a lot of IO lines, but with kids they do that. I was really surprised. I didn't, because I'm not a clinician, I'm not a provider. I've always worked on this side of the house. But in all the reviews that we do of claims, it is unusual that we see IO lines, but they do it with kids. That's an automatic ALS too. Okay? And remember, a specialty care is a facility to facility transport. And though you do not have in the state of Louisiana a level of paramedic that is above your current level of paramedic, if you have a nurse on board or a respiratory therapist and this is a critically ill or injured patient that's going facility to facility, that is a specialty care transport. And it's the highest level of reimbursement for ground ambulance. Okay? ICD coding, we talked a lot about that earlier. Be careful here that we'll see ESRD or abnormal gait being the only code on the claim. We know that ICD-10 coding is going to require a whole lot more, but remember, it's not the patient's diagnosis that drives the train. It's the mechanism of injury, it's the history of present incident, and we talked a lot about mechanism of injury, and I talked to you about swimming. Under ICD-9, swimming, if the patient was hurt while swimming, we would code swimming. But under ICD-10, where they were swimming makes a difference. If they were swimming in a lake and they got sucked into the muck like quicksand, then that where becomes part of your coding and your description. If they were swimming in an ocean, that becomes part of your description. We can impact public health and safety by how we code, and we're going to have to do a lot about the where, the how, and the what. Fraud, oh my gosh. Oh my gosh. So I have a great story about my son. So my son is a dialysis recipient, and Philadelphia has the distinction of being the second worst city in the country for ambulance fraud. And when he first went into renal failure, he was going to a dialysis facility in Philadelphia. And we have very narrow streets. They're one way, very, very narrow streets, meaning one car can get down at a time. So I take him one Saturday morning to dialysis, and I can't get too far at the street. So I'm kind of at the top of the street. He gets out of the car and he walks over to the dialysis facility. In front of me, on the left, a little ahead, is an ambulance. And the ambulance was sitting there for a little bit. I can't get around. There's too many cars. There's ambulances. And the front door of the ambulance opens up, and two guys get out, and this is how they're dressed. Not in nice shirts, not in uniforms with their badge, just a t-shirt, and all the t-shirt says EMS. No identifying information of what EMS agency, nothing. In shorts and sneakers. And here's the one. He's texting away. This is how he strolls to the back of the ambulance. He gets to the back of the ambulance, finishes the text, pockets the phone, opens the door, but now his partner comes around. They reach in, they pull out the stretcher, put it on the ground, unstrap it. The patient gets up off the stretcher, walks across the street, opens the door to the dialysis facility, and waits there. My buddy with the phone has taken the phone out, and this is how he moseys, which is so dumb to do on a Philadelphia street, but he moseys himself across the street. His partner comes pulling the stretcher. They get to the door of the dialysis facility. The patient gets back on the stretcher. They strap him in, and in the door they go. And I'm sitting there and I'm like, oh my God, they write my material for me. Seriously, dudes? Wow. Now, I do not know that that particular transport was billed to Medicare, but I kind of think, since my whole stinking city's on moratorium, and we had one provider on the border of Philadelphia and one of the surrounding counties last year who made $800,000, and all he did is transport 12 patients, I'm kind of thinking that bill might not have been too kosher. Just saying. Just saying. What's that old saying? A few bad apples spoil the barrel. So, tremendous focus on us. And this is only going to increase. And by the way, it is no longer just Medicare, it is Medicaid. And welcome to the land of commercial audit. There are 55 million people in Medicare. 30% of that 55 million are in a Medicare managed care plan. And those people can audit you. Aetna, United Healthcare, Kaiser, Blue Cross, the Medicare and Medicaid managed care plans not only have every right to audit you, they are required to by the federal government. They can audit you without showing up at your door. And here's what they do. They have this thing called extrapolation. So, everybody's going to get a routine request for audit. They want 40 claims, they want 30 claims, something like that. And you'll send them to them. And they'll look at them and they'll say, you know what? 12% of these aren't good. We're going to extrapolate over all the claims you sent us in the past 4 years. We want 12% of all our money back for the past 4 years. That's extrapolation. Isn't that cool? Now, I have a business degree. I went to a good business school. I was blessed to go. I got a scholarship. It was awesome. I learned a lot of statistics in business school. And statistics has to have some facts to back it up. First of all, they never verify that there's a real problem with all 12%. And extrapolating over the whole volume of all your claims, that doesn't meet the math test. It's not a good statistical approach. They didn't take a statistically valid random sample of all your claims. These are phrases that you use to push back on them if you get this kind of an audit. And if you have an audit situation that's bad, seek help. And there are a ton of attorneys out there that specialize in this. I work for Page, Wiltberg, and Worth. Good guys, they do this. Chris Kelly in Georgia, he does this. Matt Stringer and Margaret Kevney up north. Matt Stringer is like ferocious about pushing back on Medicare. David and Brian Werfel. These are good guys that are experienced at doing this, and if you get yourself in a mess of trouble where you're like, what the, WTH, what's going on here, why are they doing this, then get yourself some help, all right? And if you ever need a list of those guys again, email me, I'll give them to you. And then if you get yourself in trouble, the other thing I would recommend is this is not a cheap proposition to get yourself some help. So talk to a couple of them and see what it is they would do for you and what the price tag is for it so that you can make a good quality decision. Okay? But what has happened because of the bad apples is that we have had a lot of focus on us. And it's not only the bad apples, it's a requirement of the ACA. So ACA said we're going to expand coverage and services. We need a way to pay for it. And how we're going to pay for it is we're going to eliminate fraud. So they are required to do this. They're required to eliminate fraud and come after it. But they also have another approach. Instead of just auditing, they're doing things proactively. Instead of what they say, pay and chase, they want to eliminate problems. So they'll put edits in their software. And that's kind of what happened with Cahaba. Cahaba said, we're seeing far too many emergencies. This is the Carolinas and Georgia. Far too many emergencies. So we're going to put edits in, and we're going to deny all ALS 1 emergencies. And we're going to ask them to all send in their documentation. And they do not read swiftly through your patient care reports. What's more, they're not trained in this. So it is up to us to make sure we have things as right as they can possibly be from the get-go. And if appropriate, do not take their nonsense from them. Push back. Push back. You just might need help. Because, as I've said to you earlier, we have, compared to other healthcare providers, grown dramatically in our use of services. And because of that, it has put us on the radar. And I have two things coming up. I'm going to do a new blog on this. I'm going to write an article on this, on where we're falling in the overall issue. And there is a list of the top 10 types of providers that have had an uptick, and you have internal medicine being first, and then you have two other groups of physicians. Ambulance is fourth in how much we have grown in the use of services beyond other doctors, beyond cardiologists, beyond family practice. We have grown, so that's put us on the radar. And even though we do not make a lot of money, we are using more services than other healthcare providers. So we will continue to be under close scrutiny. And in Philadelphia, they put us on a moratorium. They put Houston on in July of 2013. They put Philadelphia on in February 2014. This February, they said, you know what? We're not taking it off. We have not seen enough improvement. Palmetto looked at ambulance providers and it said, we're going to deny 6,200 claims because of lack of medical necessity documentation. We're going to deny another 3,700 in the 3-month period. You know how many service that is in the 3-month period? All those trips for signature issues. So the burden is on us, not to just document, but to be careful how we bill, because you're the ones who are making the decision as to whether or not the claim gets submitted. And the challenge for you is, but I'm a billing department, or I'm a billing company, it's my job to bill. And it's your job to bill the right thing. But I'll get in trouble. You're going to have a serious look inside to say, is this something that I can help change within my organization, or is this the right organization? When you have a signature issue, you can do something about it. Even when it's a PCS, you can do something about it. And I want to talk to you about that in a couple minutes, of what you can do about PCSs to see that you have the best PCS possible and you're not losing the opportunity. But if you have a signature issue, you can do something about it. If it's your crews, you can send it back to them for a signature. If you don't have a signature from a patient, you can bill the patient.